I'll switch. So we talked about chronic vascular disease. We talked about atrial fibrillation. Maybe I'll end with what I'll call medically ill and DVT, VTE prophylaxis. I think the agents have all been shown to help with at least treatment of those. But in thromboprophylaxis, maybe Sean, you could tell us a little bit about how you think about some of the data from the agents there. And certainly, I know there's been a conversation from Mariner and others about how we think about these patients.
Yeah, so it's a really interesting area. So the Mariner trial was a 12,000 patient trial that looked at patients who were acutely ill and randomized them to 10 milligrams of rivaroxaban versus placebo, and treated those patients with rivaroxaban for 45 days, looking at events of clinically significant DVT-PE. And what the trial found was that there was no statistically significant difference in the rivaroxaban arm versus the placebo arm. And I think people were somewhat surprised.
Sorry, was the placebo arm warfarin?
No, it was no therapy. It was no therapy because this was an extended treatment. It was extending the medically ill prophylaxis out past hospitalization. So, it's an interesting population because when you look at DVT,
oh yeah, so it's not a DVT population. It's just medical
prevention. It's prevention. But when you look at patients that go on to have DVTs after hospitalization, about 3/4 of people that have DVTs have them within 30 days of hospitalization. So those patients that leave the hospital, it's a high-risk period. They usually have higher rates of inflammation. They are less mobile for a lot of reasons. Those patients tend to have higher risk, higher event rates. But in Mariner, there was no statistically significant difference in clinically significant events. But again, that was, I think, somewhat surprising to people. That was really a follow-up trial to Magellan. And in the Magellan trial, it was also a rivaroxaban study, but it included asymptomatic DVT. And so when you look at all the trials that were done, including Magellan, they all showed that there was
there's a population
decrease. Yeah, there was a decrease in the rates of DVT-PE events, but it was mostly in the asymptomatic population. And so there were signals in Magellan that showed that there might be a difference in clinically significant events. And so again, that's why Mariner was done. But unfortunately,
well, I think it's really important to know that it's one of these things we often do in trials. Like, who's the population that gets the benefit? And putting the two trials together, there's at least some indication that there's a benefit and some therapeutic use potentially there in those patients. But I think one of the things I would say is the risk score and then high D-dimers. I tend to identify patients that are medically ill that have a higher risk. But I think each individual now in practice, this is less like our AFib data where we're very clear. Here, I think you're going to be careful about that population that's medically ill that's getting extended.
Yeah, and I think we still need to identify the exact population and the exact risk scores. I think you're right. I think that there is a subpopulation that truly is going to benefit for longer-term prophylaxis after hospitalization, but that population's a little less clear.
What a tremendous time, though. I mean, Rob, to your point, when we started this, we were trying to replace warfarin for AFib. Now AFib plus PCI. We didn't talk about mechanical valves. We will come back to that. That's a future date probably. Then we talked about chronic vascular disease, treating DVT-PE, and now indicated and able to potentially do some medically ill patients that have thromboprophylaxis. So it's been a pretty amazing 10 years, if you will, about evidence, and certainly some of these compounds have gotten several indications. Chris, maybe I'll end with saying, we talked about the agents, we talked about how we got them through the non-inferiority barrier into actually effect. How big a deal what are the risks of extended thromboprophylaxis, and are the reversal agents and those that are now on the market helping? Are you seeing them used a lot? Tell me about that.
I think really not very much, Manesh, and I do think the challenge is defining the population. It's such a heterogeneous group. It includes patients who've had pneumonia, patients who are debilitated, going to skilled nursing facilities.
Cancer data now with patients with
cancer, heart failure. So I do think there are the high-risk patients, some of whom are getting treated, who are essentially still, bed-bound, but with some chance of ultimate recovery, where the risk is so high that this is better. They used to be sent home on enoxaparin,
right?
And this is a lot easier and less expensive. So I think for that, there is a population where it's being used, and I think the data are strongly supportive of it, but it's still a pretty small population.
Yeah, I think that's probably right. And then I think about just overall use of NOACs now. You would say what a blockbuster it's been for the care of our patients, and the number of indications and things that were actually making their lives easier and hopefully having less bleeding and actually having less strokes or thrombus in their legs or coronary events. So it's been a pretty big effect.
And I think it has, but, and I think we're on the threshold of even a bigger game changer, and that is as we sort out over the next 3 to 5 years how to deal with asymptomatic, silent or clinically silent atrial fibrillation, which brings us back to one of the very first questions, the duration of AFib, how much is enough, how much is important. I mean, this is a huge population. We recently completed a trial called the REVEAL trial, where we took not asymptomatic, but patients in sinus rhythm who were Chad's VAS score of 2 plus one other risk factor, and put implantable loop monitors into them. And they had no history of atrial fibrillation. Well, 29% at 18 months had documented atrial fibrillation. It wasn't a treatment trial. Exactly the same, I think almost exactly the same percentage in the Canadian ASSERT-2 trial. So this is another huge population out there that maybe will benefit with anticoagulation, we don't know.
Yeah.
But that will change the landscape.